Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communication specialist with Quality Insights. Today we'll be having a Q&A on I did not update this. Today we'll be having a Q&A on the MDS, on the National Healthcare Safety Network updates, and on immunizations. We will open with pre-submitted questions and frequently asked questions. And if you have a question for our panel, you can submit it using the chat or the Q&A tool. And if you would like to ask your question out loud, you can raise your hand to request to be unmuted. We invite you to join us every Wednesday at 2 p.m. for more webinars in this series. Next week's topic is opioid management and substance use disorder, and we'll be joined by Dr. Denise Vanacore. And before we get started, I want to remind everyone that there is a nationwide emergency alert system test that is scheduled for 2:20 today. So please don't be alarmed if everyone's phone starts going off in about 20 minutes. And now I'd like to introduce today's panelists. We have several of our quality improvement specialists here today, Deborah Wright, Penny Imes, and Shirley Sullivan. And we're also joined by our infection preventionist, Jennifer Brown, and Quality Insights Medical Director, Dr. Jean Storm. The first question we have that was pre-submitted, it says, we are coming into the time of year that we review our emergency preparedness plan. With the increased focus on emergency planning, do you have any tips that might make this an easier task to accomplish?
Thanks, Kathy. I'm going to take that question, and it is a good question. It's something that we all really need to be thinking about, especially with winter coming. And it is a really big job when you're thinking about reviewing your entire emergency preparedness plan. So sometimes a job of this size, it's easier to break it down into bite-sized pieces and sort of review it over a few months rather than trying to accomplish the entire review over just a few days, because we all know everybody's a little bit busy every day in the nursing home. So really taking those bite-sized chunks allows you to focus on smaller areas and more in-depth manner to truly ensure that your plan's meeting your expectations. And you really want to make sure that you're including all of your interdisciplinary team, you're getting input from your staff when you're thinking about how are we planning for emergencies. Now, we do have a resource available that can help make sure that you don't miss anything on your review. We did put together sort of an emergency preparedness outline, and there's a nice checklist in there that kind of walks you through each area that you really should be reviewing annually. And then it's also important to remember, as your resident population changes, your emergency preparedness plan might need to be updated to reflect the needs of high-risk residents or special needs populations. In fact, I think we heard from somebody about something like that, Kathy.
Yes, we have another question. It says, based on the question related to emergency preparedness planning, can you provide an example of high-risk residents that would need to be included in the EPP?
And really, again, we always are talking, I think, about your risk assessment. So it's those high-risk residents in special populations are best identified through a review of your individual facility risk assessment, because everybody is going to be different. And I know we typically think about those things like the respiratory units with vents, housing residents with high oxygen needs, but sometimes we need to take into consideration some of the more common and therefore easier to overlook populations within our nursing homes. So those residents that are on the regular units, but maybe less easy to identify, who would be at greater risk for an adverse event during an emergency because they do have specialized needs. So you really have to think about, do you have a plan in place to ensure, say, residents with a modified diet, that the consistencies are identified and appropriate fluids would be available to them, say, during an evacuation? Or what would your plan look like for evacuating a unit to the other side of a firewall while still ensuring that residents with cognitive impairments remain safe, because we know not everybody has a lockdown unit for dementia residents. Sometimes we have residents with various cognitive impairments throughout our general population. And, emergency drills, the alarms going off, that type of thing can really be a trigger for some of those residents. So you really have to think through your resident population and what you need to prepare for. So that facility assessment, working in conjunction with your emergency preparedness plans, would help make sure that you've identified known risk and that you have plans in place to mitigate those risks. So it all goes beyond a little bit more than, well, let's plan for a power outage if there is a snowstorm, as into how do we make sure that all of our residents are safe when we're looking at emergency planning. And thank you.
All right, thank you, Penny. The next question says, COVID-19 cases seem to be on the rise again. Is that the case? Is that what you guys are seeing?
I can take this, Kathy. So yes, sadly, we have been seeing COVID cases have been rising since August. And we are seeing this continual rise in our weekly reports on facility outbreaks. And it seems to be following trends from past years where cases start rising at the end of the summer, peaking in October, dropping off, and then spiking again in January. So this is really a good reminder to continue to be diligent with your infection control protocols and policies, paying special attention to areas of potential weakness and transmission, making sure staff are following precautions, that they're donning and doffing PPE properly, and doing good hand hygiene. And along with continually educating staff and residents, not only being up to date on their vaccines, but on proper infection control protocols. We also want to just give a reminder to make sure you're doing hand hygiene and PPE audits, doing them at least 2 times a week, and giving good direct feedback to your staff. And hopefully all this will help, slow the spread of not just COVID, but all the respiratory viruses that we're seeing this season.
Okay, thank you, Shirley.
You're welcome.
And sort of a follow-up question to that. It says, what PPE should be used while transporting a resident with suspected or confirmed COVID-19 infection?
In general, transporting a resident with suspected or confirmed COVID-19 infection outside of their room should be limited to medically essential purposes. If they are being transported outside the room for medically essential services or transferred to a higher level of care, make sure that the receiving facility is notified before the resident is transported. The CDC recommends that the resident wear well-fitting source control during transport if they can tolerate it, to contain any respiratory secretions, and their body should be covered with a clean sheet. Healthcare professionals providing transport should wear all recommended PPE, such as gowns, gloves, a particulate respirator with N95 filters or higher, eye protection. And this is recommended because these interactions typically involve close and often face-to-face contact with the resident in a very enclosed space, such as their room. So once the resident has been transported to a wheelchair or a gurney, before exiting their room, transporters should remove their gown and gloves and perform hand hygiene. Any staff members transporting the resident should continue to wear their respirator and use eye protection during the transport. And after they arrive, the receiving personnel and staff member transporting the resident should perform hand hygiene and wear all recommended PPE when assisting the resident transfer.
Thank you. Our next question, it says, will widespread mask mandates return with the rise of COVID-19 cases?
As Shirley has mentioned, the COVID-19 cases are beginning to rise. While some businesses and healthcare facilities have already increased their mask usage, there's not been any official updates to the guidance regarding widespread mask usage in nursing homes or other healthcare settings. Facilities should continue to consider the overall health of their residents and the level of community transmission of COVID-19 and other respiratory viruses when making decisions about implementing that broad-based masking. And COVID-19 transmission in the community, like I said, is increasing. As it increases, so does the likelihood of encountering asymptomatic or pre-symptomatic residents, staff, visitors. So facilities with a large population of immunocompromised residents or increased community transmission should consider implementing universal PPE.
Thanks, Jennifer. We just got a question in the chat that says, I'm seeing very little interest in the new COVID vaccine, pushback with encouragement. What do other facilities see? And I think it'd be interesting if some other facilities that are here today could chime in the chat what they're seeing. And I think we were discussing that on our meeting earlier today. I'm not sure which one of our panelists want to take this one.
Yeah, I mean, we were talking about it too. We're already, some places don't even have the new vaccine yet, and they are starting to hear some of the stories that are coming out and some pushback. But I think overall, what we're seeing is that there, again, even with this variant, there are more risk, especially to our elderly population, getting the COVID infection. And even though it's been mild, if they are a certain age, if they have comorbidities, they're still at risk for so many problems. And I know Jean had talked about this a little bit with what they're seeing from a medical perspective. And Jean, if you want to jump in there.
Sure. I think that we really have to remind our residents and families the significant risk of hospitalization with COVID. It still exists, that our residents are at risk to be hospitalized if they get COVID. I think that we've kind of been, I don't want to say we've kind of put down our walls. We used to be very nervous about COVID and we're not so anymore, but our residents are at significant risk of being hospitalized still if they get COVID. So I would remind them of that. Also, unvaccinated individuals have significant risk of developing long COVID and having significant complications 1 year after the COVID infection. So, I mean, there's been data that's demonstrated that individuals in over 65, significantly over 80, if they're unvaccinated and then they get the COVID infection, they have an increased risk of mortality 1 year following that COVID infection. So I think you really need to remind individuals of that. And I can certainly put together an education on the COVID vaccine, for in the coming weeks.
Yeah, and we're in, and Arlene, I say, you're saying the same thing. And even those who were updated prior to this, I think, again, that reminder and what Jean alluded to, I think we have become sort of complacent. We were dealing with a variant that fortunately did have some milder symptoms and people were getting over it more easily. But again, if you get COVID, the chances of hospitalizations, the chances of the illness continuing and having adverse effects over a period of time, we are updating all of our tools and resources also that we'll be putting out there for you that hopefully you can use to do some education with residents' families. But I think it's just really important to remind them too, like if you had a booster a while ago, it's kind of like you should be getting your updated vaccine, just like you have to get updated vaccine with a lot of other viruses that can change and mutate. So you really want to be prepared for that other variant that can easily come along. So I just think having those conversations And then we'll work on providing you with education and resources that you can share with your family and residents, and hopefully that will help. Thanks for the feedback. We always appreciate feedback from our nursing home staff who attend.
Thank you. Next of our pre-submitted questions, and if anyone else has any follow-up questions, please chime in the chat. Can you tell us the best way to prevent infection in residents who have femoral dialysis catheters? We have had many residents with these catheters be sent out to the hospital and diagnosed with sepsis.
Sure, I can talk about this one. So, that's a big issue with residents who do have dialysis catheters, period. But femoral dialysis catheters are a significant risk for our residents to develop sepsis. So enhanced barrier precautions, or EBP, are indicated when a resident does have any type of indwelling medical device, such as a dialysis catheter, when contact precautions do not otherwise apply. And enhanced barrier precautions expand the use of PPE, and they utilize gown and gloves during high contact resident care activities. And these high contact resident care activities are going to provide an opportunity for transfer of MDROs to, your staff clothing typically. And so examples of high contact resident care activities would include dressing, bathing, showering, transferring, any type of changing of linen, providing hygiene, wound care, or device care. So enhanced barrier precautions should be used during these activities.
So the next question is also for Eugene. It says, can you tell us what the new requirement for continuing medical education for Pennsylvania medical directors? Have any other regulations changed regarding medical directors?
So this is new for Pennsylvania, and I have not, I've been a medical director in Pennsylvania and both in West Virginia as well. And I've not seen this regulation before. So it's something all facilities in Pennsylvania should be aware of. And so the regulation states that the medical director of a facility obviously should be licensed in the state of Pennsylvania and shall complete at least 4 hours annually of continuing medical education pertinent to the field of medical direction or post-acute and long-term care medicine. So you really need to remind your medical director that they need to have 4 hours of CME that is pertinent to medical direction of a long-term care facility or in the area of long-term care medicine. So I would, your medical director might push back and say, hey, I'm going to do my medical CME in, COVID management, just in general. But I would make sure that the continuing medical education is really pertinent to that long-term care piece, because we don't know what surveyors are going to say is acceptable. And I would make sure that you ask your medical director for that certificate, registration, attendance, confirmation form. If they do that medical education, that they have documentation that you ask for your medical director to give to you, and then, make sure you store it somewhere in your facility so that when you have surveyors come in and they ask about the 4 hours of continuing medical education, that you make sure that you have that available to give to the surveyors. So that is the big change for the regulations, is that your medical director is required to have that 4 hours of continuing medical education pertinent to medical direction or post-acute long-term care medicine.
Thank you, Jean. The next two questions we have are about the optional state assessment, or OSA. The first question is, if you are doing a standalone EOPPS, is an OSA required?
So the simple answer to that is no. And for those that don't know what all the abbreviations are, if you're doing a standalone end of PPS, Do you also have to do an OSA or other state assessment? Is that required? And it is not required. Remember that your standalone end of PPS will still be completed, submitted through the federal database, and we do not need to do an OSA with that one.
Great, thank you, Deb. Next question says, are OSAs required with OBRAs except trackers, entries and discharges?
So no, the OSAs are not required with OBRA trackers, entries and discharges. And I really struggled with this one. This has been a question that I have received probably at least 10 times since Friday, with people trying to understand why we don't need to do an OSA with the discharge. Like, what's going to happen when our CMI comes, and are we going to have to do all these modifications? And honestly, I kept reading it, and the more I was talking to all of you, I started having the same questions. So I reached out to an MDS consultant that this is all they do, and she kept sending me the same answer back in emails and text, and I still didn't get it. And it wasn't until she said it out loud that I understood it. It basically, we have to remember, we're still doing our entries and our discharges and submitting them to CMS. That's what's going to affect our CMI report. The OSAs are only establishing our MA reimbursement. So as long as we are doing the entries and the discharges and we're submitting those, they're going to go on the right side of our CMI report. Are they going on the MA side or the non-MA side? The OSA is only establishing reimbursement. So if we are just doing a tracker, we do not need to do an OSA or that other state assessment.
All right, thank you, Deb. So that's all the questions we've received so far. If you have a question or comment, please submit them using either the chat or the Q&A tool in your Zoom menu. And you can also raise your hand to request to ask your question out loud and be unmuted. And I'd again like to invite everyone to next week's webinar, which will be about opioid management and substance use disorder. And that will be the same time and place next Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. And Deborah Wright or one of our other quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. And you can find the links to the live chats and our webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on the mailing list, you can email me at ccaudell@qualityinsights.org and I will get you on the list. And I will drop my email in the chat shortly and look to see if there are any further questions.
And Kathy, while we're waiting for questions, I did want to just remind everybody, I think most people know now, until you have the new vaccine, new booster, or if you've had a booster within the previous 2 months, you are no longer considered up to date. But NHSN, if you didn't get to listen to the live webinar that they had about 2 weeks ago, they're having a recording tomorrow. And they're going through what the surveillance in NHSN, what you need to document. So again, those NHSN webinars for anyone who does that documentation, really important for you to listen into those webinars when you get a chance. And in our Friday newsletter, we always list out webinars that are coming up. And I see there was a question, how long after COVID positive can one get the new vaccine? And Jennifer, I don't know if, or Jean, if you've read anything on that. What I was seeing is there's like not a specific wait time, but if
I didn't see a definitive wait time. CDC didn't recommend a definitive time frame, but I believe they said that you could wait 3 months following a positive COVID test.
Yes,
and I know from the
that
previous
is as
one,
well.
Jen, because you had talked about this back when we were went from the monovalent to the bivalent. I know, although they said 3 months, there were some people who volunteered at the time, and I don't know if any of you on the call in your nursing homes, some of you gave them sooner, like within 30 to 60 days. And there were, from what I understand, there were no adverse effects from that.
Yeah, it is, fine to give after they're out of their isolation period, once they're recovered from their COVID-19 infection. But some people may choose to wait that time period.
So no other questions?
I just want to also point out that if you do put like a specific question in the follow-up evaluation, because we've been seeing that lately, those evaluations truly are anonymous. So we cannot get back to you unless in that text box you also include your name or your email. So if you do have a specific question that you put in the post evaluation, please include your name or email so that we can get back to you. It's not that we're ignoring you, but they truly are anonymous. So,
or just email one of us. I mean, it's like pimes@qualityinsights.org, dwight@qualityinsights.org, jbrown@qualityinsights.org, ssullivan@qualityinsights.org. So it's pretty easy to remember. And again, Kathy always puts her information in there so that if you have anything, you can always send it to cancer. And how long after COVID should we administer the flu vaccine?
I think they mean flu shot. Yeah.
Shot, I think. Yeah. Jen, I'm giving that to you.
It's in the Q&A. It says how
Q&A.
after COVID positive should we administer?
So they're asking if
So-
someone is
so
COVID
again-
positive to get the flu shot.
Anytime someone has an active infection, we should, wait until they're recovered and well. But once they're recovered, they're okay to get their flu shot.
Yeah, I would totally agree. Once they're feeling better, then they recommend you can get the COVID and flu shot in the same day,
Mhm,
so
mhm.
yeah, I think that would be perfectly fine once they're recovered from flu.
And that's all the questions that we have so far. And as Penny was saying, I put my email in the chat. I also follow up email everybody following the webinar with the link to the recording and stuff. So you can always reply to my emails. You can always and get my email from that, or I put my email on the e-blast that we send out. There's a lot of ways to reach me if you want to be put in touch with anybody. I can always get you in touch with whoever you want to reach. And I think we'll go ahead and wrap up. I'll run over a couple quick closing items. Let's see. Oh, I think I already ran over my closing items. So I think I'll go ahead and wrap this up. Let's see. Yes, so that's it for questions. Before we sign off, we'd like to ask everyone here to answer a short evaluation of today's webinar. It's anonymous and will show as a pop-up as soon as the webinar ends. So if you could take a couple minutes to fill that out, we would appreciate it. And as Deb said, there is a box where you can leave questions and comments. And if you have a question that's specific where you want a response, please include your email address so we know to get in touch with you. I'd like to thank all of our panelists for joining us here today. And I'd like to thank all of you for joining us. And I hope that we can see you again next week. Thank you.